Good morning, everyone. I would like to thank IOS for giving me this opportunity. I'll be presenting on the topic ocular toxicity of anti-tubercular therapy, a prospective study using OCT. Now, why this is important? Because as we all know, that tuberculosis is a global challenge with millions affected annually. In India, 27% of India accounts for 27% of the global load. The present ATT regime, though is highly effective, has series of adverse effects like hepatotoxicity, nephrotoxicity, neurotoxicity, and ocular toxicity. One of which is ethambutol-induced optic neuropathy, which manifests with decreased visual acuity, color vision defects, and visual field abnormalities. So it is important to detect this early, and OCT is one investigation which can be used for this. The aim of the study was to evaluate the ocular toxicity of anti-tubercular therapy using OCT as an early diagnostic tool for structural changes in the retinal nerve fiber layer. The objective was to assess the baseline visual acuity, contrast sensitivity and color vision, and RNFL thickness in patient before initiation of anti-tubercular therapy and at 1 month and 3 month post-treatment initiation of treatment. The secondary objective was to correlate these OCT-derived structural changes with clinical symptoms and visual function parameters. It was a prospective observational study for a duration of 6 months in a tertiary care hospital where a total of 40 patients, 80 eyes were included who were initiated on ATT, which included ethambutol. The inclusion criteria was age above 18 years, best corrected visual acuity of 6/18 or better, patient who were newly initiated on ATT and who were willing to undergo ophthalmic evaluation. The exclusion criteria were any condition which could infect the RNFL. That is any pre-existing ocular condition, alcohol or smoking, systemic condition affecting vision, other ocular medications causing ocular toxicity, or patient who were non-compliant. All participants underwent a comprehensive ophthalmic evaluation at baseline, 1 month and 3 months. The investigations include best corrected visual acuity, color vision testing, contrast sensitivity, slit lamp biomicroscopy, dilated fundus examination, intraocular pressure, and RNFL analysis. SPSS software were used for statistical analysis. Now the results. This is the age distribution graph with the mean age of the participants was 42.6 plus minus 10.3 years, 24 were males and 16 were females. Now coming to symptoms, we saw at 1 month only one eye showed defect in color vision while no one had decrease in visual acuity or contrast sensitivity. While at 3-month follow-up, one had decrease in visual acuity and contrast sensitivity and 2 eyes showed defect in color vision. Now coming to RNFL analysis, at 1 month follow-up, there was mild thinning of the RNFL which was observed in 9 eyes. It average decreased from 102.4 to 98.6, which it was not statistically significant. But at 3-month follow-up, when it reduced to 94.3, it was statistically significant and it was seen in 15 eyes. Now coming to conclusion, this study highlights the potential ocular toxicity associated with anti-tubercular therapy with early structural changes detectable through OCT even before the onset of significant visual symptoms. These findings emphasize the importance of regular ophthalmic monitoring, including OCT evaluation in patient taking ATT. The further direction could be we could do a multicentric study, extended follow-up needs to be done, reversibility of these changes could be studied, and a standardized monitoring protocol should be made. Thank you.
Nice presentation, Dr. Neharika. Did you come to some kind of a conclusion that all these patients who get ATT, all the patients who are getting anti-tubercular treatment, some of them, their optic nerve will have more toxicity, some will have less, like in RNFL changes. So what conclusion did you come to of which segment of patients are getting more affected or less affected? Because getting affected, we know for many years that ATT medicines affects the optic nerve. But were you able to read some conclusion?
Some patient with comorbidities had higher risk, like because ethambutol is excreted by kidneys. So patients who had kidney diseases were affected more than other patients.
You have included and mentioned that in your study?
Sir, it is an ongoing study. This is a part of that study, so I'll be publishing it.
What do you think is the reason that those who have kidney disease have more optic atrophy
Sir,
changes?
because ethambutol is excreted by kidneys, so there is decreased excretion of kidneys in patients who have kidney diseases, so ethambutol toxicity is more in them.
Thank you.